No measurements?
Do you have another ideas? Now we need attention. Guys, as usual, don't try this. Please me. Region of the pelvis. You will study this region during many years because that is the base of your gynecological, for example, topics, urological topics. Say small pelvis and content of the small pelvis is critically important for these departments because here we have genital system, here we have the part of the urinal system. But base of this education I will give you today. We will speak about topographical specificities, but as usual, guys, point number one in which I want to attract your attention, it is not the topography, it is importance. Importance of the region of the pelvis. We must understand which kind of disorders we can have here. And point number one, what I want to mention, guys, it is the diseases of mentioned systems. Gynecological problems, urological problems, problems connected with the male's genital system. Let's say this is also an important compartment. Which problems I mean? Number one, of course, it is, guys, oncological disorders. Number two, it is inflammational problems. Very important. And for females, of course, primary, it is pregnancy, different violations of the pregnancy, different kinds of inflammations of the organs. Yeah, again, oncological disorders. Also, attract your attention into the bony skeleton of the pelvis. And don't forget that it is important from the point of the view of traumatology. We can have different kinds of the fractures in the region of the pelvis. Very dangerous situation, by the way, because during the fractures, the sharp margins of the pelvic bones can damage the neighboring structures with formation of internal bleedings, dislocations, anything else. Let's say traumatological importance of the region, again, very, we can say, prominent for us, necessary to know. From that point of the view, guys, you must be able to recognize the borders of the region. You must be able to understand accesses into this region, surgical accesses into this region. Partly it will give you, I will give you it today for you. Partly, again, I tell you, friends, listen me. White coat, please. Partly you will study it during the next your cycles, clinical rotations about the mentioned clinical disciplines. That's it. We will longly work inside of this region. Now, okay, as usually, guys, we must to start from the borders. I forget to take for you the bony skeleton of the pelvis. Don't worry, in the practical classes, I will take it for you. By the way, guys, don't forget that we must to make the practice. Remind me, please, intestinal sutures, you must to train. Unfortunately, previous week, majority of the students from your groups didn't come to your controls. This, you know, in previous, or we will have it in this week. Sorry. Anyhow, please, to be very attentive, because all these material will go to your examination. Okay. Bony pelvis. Then we say bony pelvis, guys, we imagine generally several bones, yeah, from in front to behind. This is your pubic bone, this is your iliac bone, this is your ischiaticus bone, and from backside it is the sacrum. All these bones connected to each other, and all of them together forms the bony skeleton of your pelvis. Now, I don't have time to speak about synastosis, which is formed here, syndesmosis, which is formed. You know it from anatomy. If you don't know, refresh your knowledge. That is not about my subject. That is anatomy. What I want to mention now exactly, borders, guys. Now write, please, the borders of the pelvis. Borders of the pelvis. Number one. Greater pelvis, otherwise false pelvis, located above superior pelvic aperture, superior pelvic aperture and belong to the region of abdomen. Once again, first compartment of the pelvis, which is called greater pelvis, it is located above the superior pelvic aperture and it is belong to the abdominal region. Number two, true pelvis or small pelvis, located below superior pelvic aperture, and it is the separated region or cavity of the human body. Separated region or cavity of the human body. Now we need attention to me. As you can see, this red, green, and portionally blue line, it is your superior pelvic aperture, or we call it pelvic inlet. And above this pelvic inlet, we have some cavity between the iliac bones primarily. This cavity we call greater pelvis. And this cavity doesn't belong to the true pelvis. It is false pelvis. And in reality, it is part of your abdomen. What does it mean, part of your abdomen? It means it contains two cavities, anteriorly peritoneal cavity, posteriorly retroperitoneal space. So everything which we studied before, inferiorly will have the relation with this greater pelvis. Yeah? For example, your loops of small intestine will reach the greater pelvis. Portions of your, for example, genitourinary system, which is covered by the peritoneum, will belong to the greater pelvis. For example, uterus. Yeah, you know that the fundus of the uterus, it has intraperitoneal coverage, and it's located in the greater pelvis. What does it mean? It means it's located above the pelvic inlet. But below this pelvic inlet, we have a real pelvis, otherwise we call true pelvis, which is contain the organs of the pelvic cavity. Let's say in your mind, make this division and recognize, please, that when we speak generally about pelvic bones, inside of these pelvic bones, we have partly abdomen, partly the pelvis. And border between these two compartments, it is the line which you see in this picture. Now write, please, the borders or formation of pelvic inlet or superior pelvic aperture. Number one, write, please, it is superior margin of the pubic symphysis. Number two, it is posterior border of the pubic crest. Number three, it is the pecten of the pubicule, pecten pubicule. Number four, it is the arcuate line of the iliac bone. Number five, it is the anterior border of the wing-like ala of the sacrum, upper border of the wing-like ala of the sacrum. And number six, it is upper border of promontorium of sacrum. Now everybody look to the picture. I will show all these mentioned structures. Now, superior margin of the pubic symphysis, and you can see it is come to the pecten pubicule. Then it is continuous to the arcuate lines, the red part. Then it is come to the green part, it is the wings of the sacral bone. And finally, it is reached, as you can see, upper border of the promontorium. Let's say all these mentioned structures together forms the pelvic inlet or superior pelvic aperture. Now write, please, inferior border of the pelvic region forms by inferior pelvic aperture or pelvic outlet. From anteriorly to posteriorly, it is passed by the inferior margin of the pubic symphysis, by the inferior roots of the pubic bones, by inferior roots of the pubic bones, by ischiadic tuberositas, inferior margin of the ischiadic tuberositas, by inferior margin of ischiadic tuberositas. Then it is continuous by sacrotuberal ligaments. It is continuous along the sacrotuberal ligaments up to the imaginary line from ischiadic tuberositas to the tip of the coccyx. To the tip of the coccyx. To the tip of the coccyx. Now, let's imagine, guys, how it is provided. For example, here you can see it is the pelvis, the view from downwards. Let's say you can see inferior margin of the pubic symphysis. Then you can see the inferior branches of the pubic bones. We come to the tuberositas ischii. From tuberositas ischii, here it's not written, it is the sacrotuberal ligament. And finally, it is the imaginary lines which is connected it with the tip of your coccyx. With the tip of your coccyx. Let's say this rib, which is shown in front of you, partly again I say it is absent here, you don't see it. By the way, I want to remind you these two very, very powerful ligaments. This is sacrotuberal ligament, and that is the sacrospinal ligament. I don't know why all this happened. I don't understand, guys. What does it mean? I try to find it, but you don't find it. Okay, thank you very much. Look here, please. This is sacrospinal ligament. This is sacrotuberal ligament. You remember they border two apertures, which is make communication, between your pelvic cavity and between the gluteal region. This is the greater ischiadic foramen and the lesser ischiadic foramen. Of course, little after we will describe the borders of these apertures. Same apertures we will describe in the gluteal region also, because they form the communications between the pelvis and between the gluteal region, place of the passage of the gluteal neurovascular bundles, as you remember. Yeah? But now keeping in your mind, let's say, remember, please, your tooth pelvis has two apertures. Upper one we call pelvic inlet, lower one we call pelvic outlet. Let's say, keep it in your mind and remember. Now write, please, pelvic outlet, covered by two muscles, Number one, it is the urogenital diaphragm. Number two, it is pelvic diaphragm. In the brackets, write, please, urogenital diaphragm located anteriorly, surrounding apertures of urinal and genital structures. For the females, it is two apertures. It is the urethral aperture and the vaginal apertures. For the males, just one aperture. It is the aperture of the urethra. And it is presented by one important muscle, which is called musculus transversus perineum profundus. Musculus transversus perineum profundus. Musculus transversus perineum profundus. Pelvic diaphragm surrounding the anal aperture of the rectum, and it is presented by musculus levator ani. 1 minute attention into the picture. What does it mean, guys? It means that pelvic outlet covered by the muscular structures which is form floor for your lesser pelvis. And this floor of the lesser pelvis presented by two powerful muscles. One is located anteriorly, second is located posteriorly. Especially for you, I cover these muscles by colors. Let's say the green structural unit which you see, it is the, of course, you can see here female's anatomy. Yeah? Let's say you see three apertures. It is the urethral aperture, vaginal aperture, and the anal aperture. Let's say the green structure which is located in the level of the first two aperture, it is musculus transversus perineae profundus. A red structure which is surrounding your anal aperture, it is musculus levator, which is divided into three portions from anatomy, you remember, according to the place of its attachments. Yeah? But generally, this is two muscles, which you must remember. Now, let's, guys, everything which you study, you must, first of all, to imagine. Let's say, imagine what is happening. Between pelvic bones, as I say you, we have two compartments, greater pelvis and lesser pelvis. Lesser pelvis from downwards has the real border, which is presented by these two muscles. From upwards, it has imaginary border. This is very important to understand because these linea terminalis, which I described for you, it is not the real wall. It is the imaginary round-shaped line. Let's say right and remember it, please. From upwards, true pelvis is open and make communications with the loose connective tissue species of retroperitoneal space. With loose connective tissue species of retroperitoneal space. In the brackets, right, please. But it doesn't have real connection with the peritoneal cavity due to the most inferior portion of the parietal peritoneum. Which is covered pelvic structures from upwards. But it doesn't have immediately communication with the peritoneal cavity due to the specificity of the most inferior portion of the parietal peritoneum, which is covered the upper surfaces of the pelvic structures. That structures, my dear friends, will be called extraperitoneal structures. We don't say retro, because retro will be for retroperitoneal. We say extraperitoneal structure. How you can imagine it? Now let's imagine that my room, it is the true pelvis. This upper round line which you see, it is the arcuate line. In reality, my roof, it will be the parietal layer of the peritoneum, which is come downwards and which is covered terminal structures, which is located inside of the pelvis. You understand it or no, guys? This is important to recognize, important to understand. That's like if I will want to make the direct communication to upwards, it will be possible from backside to the retroperitoneal space, because backside loose connective tissues without interruption will come to the pelvis cavity. But from in front, it will be not possible. And this border, guys, between this anterior and between these posterior structural units, approximately, look in the picture, please, will be coincide between the borders between urogenital diaphragm and the pelvic diaphragm. Pelvic diaphragm will be related with retroperitoneal space. Urogenital diaphragm will be related with the peritoneal cavity. Attract your attention into this question. That's like we don't have direct communications with the region of the peritoneal cavity. Indirect communications we have, but direct communications no. Why? Because the peritoneum will separate this connection. Idea is understandable for you guys. If it is understandable, write please. Next question. Fascias and loose connective tissue spaces of the tooth pelvis. Right, please. Continuation of endo-abdominal fascia to downwards, below the pelvic inlet, with rename and call it pelvic fascia. Continuation of endo-abdominal fascia to down, below the pelvic inlet, we rename the pelvic fascia. And this pelvic fascia, right, please, exactly inside of the tooth pelvis, split it into two terminal layers, parietal and visceral. Parietal and visceral. Write it, please, and attract your attention into the picture. Attract your attention into the picture. Now, 1 minute, look everybody here. The green structure which you see, it is the parietal layer of the peritoneum. You can see that from the peritoneal walls, it is spread into the peritoneal floor. Let's remember together, guys, that this peritoneal floor will form depressions. As you remember, for the males, we have two main depression, or one depression and one retius pocket, which is located in front of the urinary bladder. For females, we have two depressions, recta uterine and utera vesical one. By the way, recta uterine, as you remember, it is the lowest point. We call it the ductus as you remember. Okay, but attract your attention now into this blue structural unit. This is fascia endo-abdominalis. By the way, space between these two fascias we call retroperitoneal space. As you remember, in anterior wall it is the Langenbeck space. In the posterior wall it is the retroperitoneal space. Together in the last lesson we discussed this question. And attract your attention, guys, approximately in the level of the linea terminalis, it is split into these two layers. Now look at please, layer number 1 covers the walls and the muscles which is presented in this wall. Layer number 2 continues to the organs. For example, you can see urinary bladder. And cover the organs which is located in the small pelvis. That is division of the pelvic fascia into the parietal and into the visceral layers. It is understandable for you. Let's remember please. Pelvic fascia, it is continuation of endo-abdominal fascia. Below linea terminalis, it is split into two terminal branches, parietal one and the visceral one. Parietal cover the walls, visceral cover, right please. Parietal layer cover the walls of the small pelvis with the muscles which is presented in these walls. In the brackets, right, please, musculus piriformis, musculus obturatorius internus, musculus coccygeus, and it gives two branches into the floor of the pelvis. In the brackets, right, please, superior branch cover two diaphragms from upwards. Inferior branch cover both these diaphragms from downwards. Both these diaphragms from downwards. Let's say, guys, pelvic diaphragms cover not by one, but by two layers of the parietal portion of the pelvic fascia. Both diaphragms from upwards covered by upper layer, from downwards they covered by the lower layer. Let's say keep it in your mind. This is very, very important. Right, please, according to position of these fascias, in the inferior portion, parietal and visceral layers, parietal and visceral layers fuse to each other and connected with arcus tendineus, fascia pelvis, the tendinous arch of the pelvic fish. That is the place of jointment of two diaphragms. Yeah, as you remember, diaphragma pelvis and diaphragma urogenitalis, they joint to the bones and they forms the tendinous arch. Pelvic fascia also fused to this tendinous arch, by the way, by its both layers, by its superior, by its inferior pelvic diaphragmatical fascias. They fuse to each other along the line which we call pelvic outlet, yeah? And along of this line it forms the arcus tendineus of the pelvic fascia. So remember, please, and let's continue. Now, right, please, the visceral layer cover the organs of the pelvis, and it is separated from organs with thin layer of the loose connective tissue, with the thin layer of the loose connective tissue, which is called visceral loose connective tissue of the pelvis, visceral loose connective tissue of the pelvis. In the brackets right, please, usually we call it by the term para. In the brackets right, please, paravesical loose connective tissue, parametral loose connective tissue, paraprostatical loose connective tissue, paraseminal loose connective tissue, and like this. Para, it means surrounded. That's a minute attention, guys. Visceral layer come to the organ, cover this organ, but doesn't fuse with the wall of the organ. Between visceral layer and wall of the organ, we have loose connective tissue space, which we call visceral. Otherwise, we call it by the term para. Pararectal, paravesical, parauteral, or parametral, call how you want. Let's say this is visceral. Vice versa, continue please. Between parietal and visceral layers of pelvic fascia, between parietal and visceral layers of the pelvic fascia, we have parietal loose connective tissues, we have parietal loose connective tissue spaces of the pelvis, which is called by the name of the organs, which is border dimension spaces, like prevesical, retrovesical, retrorectal. That's according to the organs which is border this space, yeah, we call it according to the name of these organs, yeah, according to the position. A little after we will speak, we will discuss about it, but just now attract your attention into this horizontal section of the pelvis. That is approximately in the level of the tuber ischiaticum. And you can see here the yellow loose connective tissues. By the way, if you will look attentively, the visceral layer of the fascia shown here by interrupted line. And if you will look attentively between this black interrupted line and wall of the organ, there are very thin loose connective tissue, which we call visceral. But if you will look now to the main parts of these yellow structures, you will see that they located between these non-interrupted and interrupted lines primarily. And it will be the parietal portions of the pelvic loose connective tissue. Say, pelvic loose connective tissues, according to localization, divided into the parietal portion and divided into the visceral portion. Now write please the name of the next topic, division of the pelvis, topographical division of the pelvis. Write please, from topographical point of the view, pelvis divided into three floors. pelvis divided into 3 floors. First one we call peritoneal floor of the pelvis, cavum pelvis peritoneale, peritoneal floor of the pelvis. Second one we call subperitoneal floor of the pelvis, cavum pelvis subperitoneale. And third one we call subcutaneous floor of the pelvis, cavum pelvis subcutanea, or otherwise we call it fossa ischia rectalis. Peritoneal floor, subperitoneal floor, and fossa ischia rectalis. Now, minute attention to me, guys. I speak now about the truth pelvis. We don't speak now about the false pelvis. It is the truth pelvis. Otherwise, we describe the structures which is located below the linear quadrant. And from that point of the view, you can say, sir, how is it possible? You told us that from upwards, the pelvis is covered by the peritoneum. But don't forget about depressions, guys. I told you before that the parietal peritoneum, which is covered the floor of the peritoneal cavity, forms very deep depressions. And these depressions spread it into the truth pelvis. Do you understand me? If we will not have depressions, we will have from upwards absolutely straight wall, yeah, which is covered us and bordered from the peritoneal cavity. But due to these punches, due to these depressions, partly this peritoneum descended to downwards. This is very important to understand, guys. And due to this, for example, our friend, it is some organ, yeah? She will have not only upper coverage, but from sides or from in front or from behind. Let's say, which kind of phenomena it forms? It forms the unique phenomena that part of the organs which is located inside of the truth pelvis will have the peritoneal coverage, mesoperitoneal or intraperitoneal. It will not be the complete organ. It will be only portion of this organ. And this is understandable for you guys. This is very important. These are right, please. Due to formation of the depressions by parietal peritoneum, which is covered inferior floor of the peritoneal cavity, part of the peritoneal organs, part of the pelvic organs, will be covered by the peritoneum. Will be covered by the peritoneum. In the brackets, write please, mainly in mesoperitoneal form, from 3 sides. Very seldomly we can have an intraperitoneal portional structures. In the brackets, write please, example of these organs. It is uterus for the females after the pregnancies and deliveries. In the brackets, write please, it is intraperitoneal structure. Posterior wall of the fornix of the vagina. Posterior wall of the fornix of the vagina. Number 3, it is of course urinary bladder. As you remember, then it is full by the urine, it's come to the mesoperitoneal structure. Next one, it is seminal vesicles, which is also mesoperitoneally. Some literature even say intraperitoneally. If it will be upper location, they can be covered from all sides. Ovarium, which has the mesoperitoneal structure. Mesoperitoneal structures. Rectum, guys. Here it's important to mention which portion of the rectum I mean middle portion, guys. Upper portion of the rectum, which is intraperitoneal, located in greater pelvis, but middle portion of the rectum located exactly in the small pelvis. This is place of the passage of the peritoneum, yeah, from 3 sides into 1 side. Lower portion, primary it is infraampular portions, yeah, will have the extraperitoneal coverage. That's how, remember, please, that is the organs which is located in small pelvis. But do you see which is organ is it? This is organs which is related with the depressions, guys. In the region of the depressions, due to the mechanical protrusion of this peritoneum to the downwards, part of the walls of the organs will be covered by mentioned structural units. Idea is understandable for you. In the brackets, write, please, the floor of the recto-uteral depression, which is called the Douglas space, by the special aponeurotical structure, which is called aponeurosis peritoneo-perinealis, peritoneo-perineal aponeurosis, or otherwise by the author name, we call it Denonville's fascia, Denonville's fascia, fuse with the pelvic diaphragm in the level of the jointing place between pelvic and urogenital diaphragms. And by this connection, it is fixated the Douglas space in its most depressed position. 1 minute attention to me. What does it mean? Now let's imagine that my roof, it is elastic structure, rubber structure. I take this roof and connect it with the floor. And I glue it with the floor, guys. Due to this depression, which will be formed in this region, will be fixated. For example, I'm sorry, if you will stand up in your head, depression still will be connected with the downwards located structures and cannot make, for example, exvagination to upwards. That's why due to this connection which we mentioned here, depression will be fixated. By the way, in this horizontal section, you can see this Denonville's aponeurosis, which is located exactly between the rectum and between the uterus. This is the place of location of the depression. And as you can see, guys, it is come from up to down, and here downwards it is fused with the pelvic diaphragm, just in the place of the junction between pelvic and urogenital diaphragms to each other. And due to this, it is provided the mentioned fixation. Idea is understandable for you guys. Very well. Great. Right, please, the floor number 2. Floor number 2, guys, it is located below the mentioned depressions, between the lowest part of the peritoneum inside of this depression, and between the pelvic fascia, which is covered the pelvic diaphragms. Do you understand me? That's why we come up to the lowest part of the depression, and from that place we descend into down up to the pelvic diaphragm, which is, you remember, covered and from upwards and from downwards by the pelvic fascia. Imagine immediately now we come to the upper surface. That's right, please. Inside of this floor, we describe the extraperitoneal portion of all pelvic organs, which is the majority of them. It is the uterus for non-pregnant and not delivery females. It is the vagina. It is the urethra. It is the prostate. It is the lowest parts or empty urinary bladder. It is inferior parts of the seminal vesicles. It is ovarian testicular vessels. It is the common iliac vessels with their divisions into the internal and external iliac vessels. It is inferior caval vein. Let's say all these structural units, guys, located below this level. And how they cover? They cover, guys, extraperitoneally. Only the most upper portion of them can be covered, or they doesn't have any coverage by the peritoneum, like the prostate. Idea is understandable for you guys. Let's say keep it in your mind. This is not easy to understand. Let's say you make the mistakes. First of all, let's do once again this description. Now let's imagine that the corner between my walls and between my roof, it is the linea terminalis, or pelvic inlet. In the reality, if it will be so, my roof will not be straight, it will be depressed. It will be depressed to downwards. How much it will be depressed? The most deeper portion will be called the excavatio recta uterina, or Douglas space. Let's imagine, for example, that it will be up to the level of this table. For example, this roof descended up to the level of the table, then again ascended to upwards. For females, one more, not so much deep depression, will be in front of the uterus, between the uterus and the urinary bladder. Now look to me, guys. What is the floor number one? It is from corner up to the level of this table. We will call it cavum pelvis peritonealis, or first one. What is the second floor, guys? This is between this table and between the floor. Do you understand me? Logically, what will be the third one? Below this floor. 1 minute attention. The problem, guys, that the pelvic diaphragms located little bit upwards to the pelvic outlet. And what will be happen? Pelvic outlet, which is the border, of our pelvis from downwards, will be not related exactly with these muscles. Muscles will be upward located, approximately from 2-3 centimeters up to 6-7 centimeters in the region of the anus. The muscles will be located upward. For example, you can see it in this picture. We need attention. This is the muscle. This is the pelvic outlet region. Tuber ischiaticum, I connected one to another. Approximately this is level. Do you see this fat which is located between muscle and between pelvic outlet? We call it the fossa ischia rectalis, or cavum pelvis subcutanea. Why subcutanea? Because here we have subcutaneous fatty tissue. Look, guys, it is not this fat. It is this triangular fat, which is located between muscles and between pelvic outlet. Because what is the inferior border of your pelvis? Pelvic outlet. But muscles related not straightly to this level of pelvic outlet, but they elevated to upwards, primarily in the level of the pelvic diaphragm, which is musculus levator ani. It has some ascending form because it goes to the level of the deep sphincter of the rectum and fused to this region. That's why, look, guys, it's very easy in the example of our room to imagine it. From the corner up to the table, it is the peritoneal floor. From the table up to the floor, it is the subperitoneal floor. Now below my floor, now let's imagine that one more corner, this corner, for example, located below the floor. Between this inferior rib and between the floor, I will have fat accumulation. And it will be cavum pelvis subcutaneous. Is it understandable? That's why keep in your mind, guys, these two landmarks. From upwards, it is pelvic inlet. From downwards, it is pelvic outlet. Which usual mistakes you make? For example, you say that cavum pelvis peritonealis, it is the lower part of the peritoneal cavity. No, it is not the lower part. It's located below peritoneal cavity. Just because of the depressions, this peritoneum portionally cover the organ surfaces. If we will not have the depressions, we will not have a peritoneal floor of the pelvis. But because of the depressions, peritoneum has a relation with the organs. I don't know how more understandable tell it for you. Right, please. The second floor, cavum pelvis subperitonealis, subperitoneal floor. Right, please. Borders from upwards. It is the lowest portion of the depressions. From downwards, it is the diaphragms. from downwards, it is the diaphragms. Inside of this space, we have organs which is not covered by the peritoneum, extraperitoneal part of the organs. We have extraperitoneal part of the organs. And we have the loose connective tissue spaces. Loose connective tissue spaces immediately will be here. You can say me why upwards we don't have loose connective, why in cavum pelvis peritonealis we don't have loose connective tissue. Easily, friend. I told you 2-3 minutes before that mainly these spaces forms by pelvic fascia. But sorry, in cavum pelvis peritonealis, instead of the pelvic fascia, we have parietal peritoneum, which is cover the organs. That's why in upper floor, we don't have any loose connective tissues. To have loose connective tissue, we must have pelvic fascia. What is the cover, the organs which doesn't have the peritoneal coverage? Pelvic fascia. And that's why in the level of the second floor, we will achieve both types of loose connective tissue spaces, and parietal and visceral. Right, please, number 1. Parietal loose connective tissues. Surrounding the main organs and located between the wall of the organ and the visceral layer of the pelvic fascia. The wall of the organ and the visceral layer of the pelvic fascia. 1 minute attention, guys. Then we will discuss about surgeries. We will mention the importance of this. Due to this specificity, pelvic fascia can be easily separated from the wall of the organ during the surgical performance because they doesn't fuse to each other. Between pelvic fascia and between wall of the organ, we have loose connection. By the way, the best developed visceral space we have in the level of the uterus. We call it parametrium. Approximately the average length of this space, it is near the 1.5 centimeters. In the level of the urinary bladder, in the level of the prostate, in the level of another organs, it is not so much developed. It is millimeters. But in the level of the rectum, it is greatly developed. Remember about it. All right, please. Parietal loose connective tissue spaces located between parietal and visceral layers of the pelvic fascia, or between parietal layer and the walls of the pelvis, or between parietal layer and the walls of the pelvis. Main spaces located in front of the urinary bladder, we call it prevesical. Behind of the urinary bladder, we call it retrovesical. Behind of the rectum, we call it retrorectal. And in the right and left sides from the main organs, which we call lateral right and left. Now, one by one, all these spaces we will discuss together. But before it attract your attention into the pictures, again I tell you, visceral spaces, if it is between these black interrupted lines and the wall of the organs, all another these much more better developed spaces, which you see, we call the parietal spaces. But 1 minute attention, you know all these mentioned structures except that two structures and those structures. What is it? Now write, please. Parietal layer of pelvic fascia in the sagittal plane gives two septas. In the sagittal plane gives two septas, which we call right and left sagittal septas. Anteriorly, they fused with the anterior portion of the tendinous arch of the pelvic fascia, anterior portion of the tendinous arch of the pelvic fascia, in the brackets write please, approximately 2-3 centimeters laterally to the pubic symphysis. 2-3 centimeters laterally to the pubic symphysis. 2-3 centimeters laterally to the pubic symphysis. Posteriorly, this septus fused with the sacroiliac joint region. Again, arcus tendineus. With arcus tendineus in the level of the sacroiliac joints. Is it understandable for you? Now, minute attention, please look to me. You can see that they pass strongly in the sagittal section. And in sagittal, and right, please, this sagittal septus fused with the visceral layer of the fascia, which is covered the organs. They fused with the visceral layer of the fascia, pelvic fascia, which is covered the organs. Which organs I mean? For the males, just 2 organs. This is the rectum and this is the urinary bladder. For the females, it is 3 organs. It is the rectum, it is the urinary bladder, and it is the uterus. If you will look here, guys, you will see that interrupted lines joined with this sagittal septus. Idea is understandable for you guys. That's a remember, please. Also right, please, from right and left sides of the uterus. Parietal layer forms the transverse ligaments of the uterus. Transverse ligaments. You know, guys, it has the function of the mesenteries in the peritoneal cavity. Because the uterus, it is the best supply structure in the female's pelvis. This parietal layer make the protrusion from right and left side, into the uterus. And from these 2 layers, guys, vessels and nerves, like inside of the ligament, will deliver into the uterus and will supply the wall of it. That's like, this is the second structure, which I showed for you before, and you can see the vessels and nerves, which is located inside of it, and which is pass immediately to the organ and make the supplement of this organ. Remember it, please. This is very important. For the males, the same structural unit located in the level of the prostate. That's again, we have the transverse ligament, which is come from the parietal layer of the pelvic fascia, and which is provided the main vessels and nerves towards it. Now, right, please. Communication of parietal and visceral loose connective tissue species of the pelvis. Communications. Number 1, right, please. Visceral loose connective tissue species. Visceral loose connective tissue species. Communicated with nearby located parietal species. And they achieve the vessels and nerves from the parietal species. Number 1, paravesical space. Paravesical space. Right, please. First point. Communicated with prevesical and retrovesical parietal loose connective tissue species. And with the right and left lateral parietal loose connective tissue species. With the right and left lateral parietal loose connective tissue species. In the brackets right, please, vesical vessels. It is the branches of the internal iliac artery, as you remember. From the right and left lateral spaces, perforated the sagittal septus, and reach the urinary bladder and supply. Consequently, veins is going in the opposite direction, draining to the internal iliac veins, which belong to the tributaries of the inferior caval vein, the venous system. Right, please. Retrovesical loose connective tissue. Hurry up, guys, time is short. Retrovesical loose connective tissue. Communicated with right and left lateral parietal loose connective tissue species. And with the right and left loose connective tissue spaces, and with the pre-vesical space. With the pre-vesical space. By the way, guys, for the pre-vesical space, I forget to mention, find the side and write, please. Pre-vesical space by obturator aperture, foramen obturatorium, which is located just in front of it, yeah? Forms the communication with superior femoral region. Forms the communication with superior femoral region. Superior femoral region. This is important to mention, guys. This is a natural channel which is located in the pelvic bones. In the future we will discuss it, yeah? And it is provided obturator vessels and obturator nerve branches into the femoral region for the supplement mainly of the medial group of the femoral muscles, yeah? As you remember here, we have the adductor muscles, which is located in the medial group primary. Okay, right, please. Space number 3, it is retrorectal space. It's located behind of the rectum, between the rectum, sacrum, and coccyx. Between the posterior surface of the rectum, sacrum, and coccyx. Many attention, guys. Usually you ask me why we don't have pre-rectal space, why we have retrorectal. In this picture, there are mistakes, guys. Usually, the non-Wills fascia located immediately in front of the anterior wall of the rectum. And between them, because it is fixed fascia, we don't have really developed loose connective tissue space. All this space located primarily behind of the rectum. Here you can see some narrow space, but in the reality, these two structural units is joined to each other. I mean the denominal fascia and the visceral layer of the fascia, which is covered the rectum. Let's say in the reality here, we don't have the space. Do you understand me? Let's say we discuss that space, which you see. Right, please. This is very great developed space, located behind of the rectum. Along the pelvic apertures, it is communicated with the gluteal regions, to upwards, it is communicated with retroperitoneal space. In the brackets, right, please, it is textus cellulosus retroperitonealis, retroperitoneal loose connective space. You remember, in the last lesson, I tell you that inside of the retroperitoneal space, we have several loose connective tissues. Yeah? It is paranephron, paracolon, and textus cellulosus retroperitonealis. That's a textus cellulosus retroperitonealis connected with 3 spaces. First one, it is retrorectal. Second and third one, it is right and left lateral parietal spaces, which we have here. Right and left lateral parietal spaces. Now, continue, please. Retrorectal space connected with pararectal visceral space. And connected with right and left lateral parietal loose connective spaces. Right and left lateral parietal loose connective tissue spaces. In the brackets, right, please, from last mentioned 2 spaces, branches of internal iliac arteries. It is the middle rectal branch and the inferior rectal, which is from pudenda interna, reach the wall of the rectum and supply it. And also in the same direction, venous networks, which is formed, as you remember, 3 plexuses, yeah? It is a subserous one, subfacial one, and subcutaneous one, yeah? And here we will have formation of the portacaval anastomosis, as you remember, guys. Right, please. Finally, the last 2 species, it is right and left parietal species. Number 1, they connected with all visceral spaces. all visceral. Why I don't give you one by one connection of visceral spaces? Because now I gave it. All visceral spaces communicated with the parietals, right and left parietal space. In the brackets, write please the main source of the vascularization and innervation. From right and left parietal spaces, these vessels and nerves will reach the visceral spaces and will make the supply. Only one exception. I told you it is the transverse ligaments, which is provided like the mesenteries, the vessels, or into the uterus or into the prostate. All another vessels, guys, without any ligaments, just from the parietal spaces, penetrated the sagittal septus, because sagittal septus fuse with the visceral layer of the pelvic fascia. I told it before. That in the place of the junction, septa is perforated and vessels and nerves immediately from right and left parietal spaces enter inside of the visceral space and make supplement of the organs. I think it is not hard to understand. Continue, please. Two upwards spaces communicated with the parietal loose connective tissue spaces of retroperitoneum. It is again textus cellulosus retroperitonealis. Through this communication, guys, biggest vessels and nerves of the human body, I mean the last parts of the sympathetic trunks, the terminal portions of your main vessels, aorta abdominalis, inferior caval vein, will descend it to downwards. Means the vein will ascend it, artery will be descended to down due to this communication. And they will come to the right and left lateral space, I mean the iliac vessels. After the division in the level of L4, L5, they will come to the lateral spaces. Inside of the lateral spaces, common iliac vessels will split it into external and internal branches, and then they will be continuous to the final destination. Final destination, internal will be finished inside of these lateral spaces by division into the parietal and into the visceral layers. Parietals to the walls, to the muscles, which I mentioned before, visceral to the organs, which is located inside of second floor. External one, also, guys, pass from up to down, from laterally to the medially, reach the level of your inguinal ligament, pass behind of the midpoint of your inguinal ligament. Here we rename it and call it femoral artery. Behind of your inguinal ligament, we have the space, which is called subinguinal space. This subinguinal space, again, this is for your review because next week, we will study the lower extremity. Now let's imagine that my floor, which is in front of me, it is inguinal ligament. Wall behind of me, it is the iliac bones. Now between these two mentioned structures, approximately in midpoint of my room, I will have the facial structural unit, which is start from one point and come to another. By the way, it is start from midpoint of inguinal ligament and come to the region of formation of junction between your iliac bone and between your superior branch of the pubic bone. We call it the pectineal junction, It is pectineal portion. And this arch, which is connected to mentioned structures, we call arcus iliopectineus. And this arcus iliopectineus, all our room, will split it into two parts. Lateral part I will call lacuna musculorum. And yesterday I told you that musculus psoas major descended to down, and it fused with the iliac muscle, which is located in the inner surface of your greater wing of the iliac bone. And together they form the iliopsoas, which is descended to your femoral region through the lacuna musculorum. In the lacuna vasorum medial part, we will have exactly continuation of your external iliac artery and vein, which is come from downwards to upwards, which is called lacuna vasorum. Also here we will have the femoral branch of the genitofemoral nerve. By the way, vein will have more medial position, artery will have lateral position. Laterally to artery, inside of lacuna musculorum, we will have femoral nerve. But below inguinal ligament, all of them will be entered inside of your femoral triangle and will form the neurovascular bundle of your femoral region, vein, artery, nerve. So keep it in your mind. You see how these three regions which we study together, retroperitoneal space, pelvis, and the lower extremity, we connect it by the communications to each other. Continue, please. Also the lateral spaces by supra and infrapiriformis portions of the greater ischiatic aperture. By supra and infrapiriformis. You remember, guys, greater ischiatic aperture by musculus piriformis, split it into suprapiriformis and infrapiriformis. Yeah? In supra we have the superior gluteal neurovascular bundle, in infra inferior together with the nervus ischiaticus, which is goes to down. Yeah? That's why from these two apertures, it is communicated, of course, with the gluteal region. And along the nervus ischiaticus with posterior compartment of the femoral region. Because ischiaticus exactly will continue to the posterior femoral region, and we will achieve communication, yeah, between the lateral right and left spaces and between posterior region. Idea is understandable. Right, please, by Alcock's channel. Alcock's channel located in the lesser ischiatic aperture, as you remember, between the sacrospinal ligament, which is split into two layers and forms the Alcock's channel. It will be communicated with last third floor of the pelvis, which we call fossa ischia rectalis. You remember, normally inside of this channel, we have exactly our pudental neurovascular bundle. You remember, by foramen infrapiriformis, it is come to the gluteal region, then it is passed below the ligamentum sacrospinalis, and by the Alcock canal, it is goes to the last floor, because it must to supply the anal portion of the rectum. Yeah, it is the pudenta interna, which is branch of your internal iliac artery. It gives the inferior rectal artery, which is supply the lowest part. That's so interesting. Look to me. Lateral space, first of all, by infrapiriformis aperture, connected with gluteal region. Transitory, this neurovascular bundle from pelvis come to the gluteal region. Doesn't supply anything in this gluteal region, then turn back. But it comes from second floor, but goes to the third floor. And due to this transition, second and third floor connected to each other. And lateral space is communicated with fossa ischia rectalis, which is located downwards. Idea is understandable for you guys. Let's say you see so many communication. Open the brackets and write, please. All mentioned communications, unfortunately, can be the ways of the passage of the pus. Can be the way of the passage of the pus. I think, guys, it's enough for you from second floor. Now write, please, the third floor. Fossa ischio rectalis or cavum pelvis subcutaneum. Call it how you want. Now write, please, borders of the space. From medial side, it is the terminal portion of the rectum, anal portion, with external rectal sphincter. From the lateral side, it is the ischiatic bone in the level of the tuber ischiaticum. Anteriorly, it is the urogenital diaphragm, but not the profundus, but superficial, musculus transversus perineus superficialis. From posteriorly, it is the inferior border of the gluteus maximus muscle. From backside, inferior border. And from upwards, it is, of course, the pelvic diaphragm. From downwards, it is the pelvic outlet. Minute attention to me, guys. Now, we speak about this triangular shaped space. Now, let's understand the borders. Medially, you come to the terminal portion of the rectum, and you come to the external sphincter. Laterally, as you can see, you come to the level of the tuber ischiaticum. If you will go to anteriorly, in front of the pelvic diaphragm, we have the urogenital diaphragm, small portion, which is transversus perineus superficialis. If you will come to behind, how much this fat will be continuous? Up to your gluteus maximus. Gluteus maximus will close its continuation to the backwards. Do you understand me? If you come to upwards, we have our roof, it is the pelvic diaphragm. If you come to downwards, we don't have real border, we have imaginary round line, which we call pelvic outlet. Let's say generally you must understand, guys, that this floor located among of all your pelvis and in the level of the urogenital diaphragm and in the level of the pelvic. But in anterior compartment, it's very thin, less than 1 centimeter. It's like it doesn't have practical meaning. Why it's happened? Hold your hands like this. Let's imagine that this is pelvic outlet, guys. From upwards in anterior portion, urogenital diaphragm, approximately it is the horizontal structure. From behind the pelvic diaphragm, it is ascending structure. You understand me? Let's say here in posterior portion, between roof and between this imaginary round line, we have the depression, which is filled by the fat. In the anterior portion, because of the horizontal position of the urogenital diaphragm, you don't have enough space between this imaginary line and between the roof. Let's say generally here, the space is closed. Here, due to the oblique position of your pelvic diaphragm, we achieve the triangular shape depression, which is called the fossa ischio-rectalis, or cavum pelvis subcutaneus. Let's say generally, it is located along of whole pelvis, but anteriorly it is non-developed, and the main its development located in the posterior portion. Is it understandable for you? Right, please. It is generally filled by the fat. It is filled by the fat. To upwards by the mentioned Alcock canal. It is communicated, first of all, with the deep loose connective tissue of the gluteal region. And second, by the cavum pelvis subperitonealis, second floor. Yeah? In the brackets, right, please. Right and left, lateral parietal spaces. Right and left, lateral parietal spaces. Meaning, attention to me. What does it mean? Alcock canal, as I say you, yeah? It is the channel which is originated from the gluteal region under the ligament due to the splitting 2 layers of the ligament. It is come to the last, third floor. Where is located the start of this channel? Start of this channel located between first and second layer of the muscles of the gluteal region. First layer, as you remember, it is gluteus maximus. Second layer, it is 6 muscles, yeah? From gluteus medius up to the lower located 6 muscles. It is piriformis, gemellus superior, gemellus inferior, up to that, all muscles which have. From that level, now let's imagine that she is first group of muscle, I am second group of muscle. Between us, we have deep loose connective tissue spaces. These deep loose connective tissue spaces by 2 apertures, one above piriformis muscle, second below piriformis muscle, communicated with second floor of the pelvis. Now what is happened? Second floor of the pelvis, right and left lateral spaces, by these 2 apertures come to the deep loose connective tissue of the gluteal region. Then immediately by Alcock's canal, it is continuous into the last, third floor of the pelvic cavity, cavum pelvis subcutaneus. That's why we have transitional connection from middle floor to the lower floor by connection inside of deep loose connective tissue of the gluteal region. I think, guys, it is most understandable explanation which I can give you. That's all, guys. This is what I want to give you. Do you have any questions? If no questions, it will be your homework. It will be your homework. Next time, I mean in practical class, exactly, I will try to make the practical some skills, and from the next week, we will start to study lower extremity. It will be the last part of your semester material, region of the lower extremity. Questions? Number of your groups.
301 and 2.
301 and 302. And date, please.
3rd November.
3rd of November. No any